Welcome to MRCPology channel for quick review, understanding of the topics, and a stepwise approach to the PACES exam. Trendelenburg test is a functional test of hip abductor weakness. In a proper lower limb examination, this test should not appear suddenly as an isolated maneuver. By this stage, you are already building a clinical impression from the flow of the exam. During gait, you may have noticed a waddling pattern, pelvic dipping, or the patient leaning the trunk over one side. During proximal power testing, you may have found weakness of hip abduction. If this is neurological, you may also be looking for L5 involvement, superior gluteal nerve injury, or associated weakness in other muscles. If this is myopathic, you may have already seen symmetrical proximal weakness, difficulty rising from a chair, and difficulty climbing stairs. So, Trendelenburg test is done to show the functional consequence of suspected hip abductor weakness. It answers a very practical question. Can the patient keep the pelvis level when the whole body weight is placed on one leg? The key muscles are gluteus medius and gluteus minimus. They are supplied by the superior gluteal nerve, mainly from L5. Their most important functional role is not simply abducting the hip. It is stabilizing the pelvis during single leg stance. To perform the test, ask the patient to stand on one leg. Let us say the patient stands on the left leg. Stand close for safety and watch the pelvis from behind. Normally, when the patient stands on the left leg, the left gluteus medius and minimus contract strongly. They hold the right side of the pelvis level or slightly elevated. This means the left hip abductors are working. In a positive Trendelenburg sign, when the patient stands on the left leg, the right side of the pelvis drops. The important point is that the side that drops is not the weak side. The weak side is the standing side. So the rule is, standing on the left leg, right pelvis drops, left hip abductors are weak. Now look at the picture. On the normal side, the pelvis remains level because the abductor muscles on the stance leg side are pulling effectively. They counterbalance the downward pull of body weight on the unsupported side. On the abnormal side, the unsupported side of the pelvis falls. This is exactly what happens when the abductors on the stance leg side fail. The red muscle in the picture represents the gluteus medius and minimus mechanism. If that muscle group cannot generate enough force, the pelvis tips down on the opposite side. The biomechanics are simple. Body weight tends to drop the unsupported hemipelvis. The stance side abductors act like a stabilizing cable. Strong abductors level pelvis. Weak abductors pelvic drop. Clinically, this solidifies the weakness you may already have suspected from gait and power testing. It converts an isolated power finding into a visible functional sign. The causes should be interpreted in context. L5 radiculopathy may come with back pain, radiating pain, sensory change, and weakness in other L5 muscles. A superior gluteal nerve lesion may cause more isolated abductor weakness, especially after pelvic trauma or surgery. Myopathy and muscular dystrophy usually give proximal weakness, difficulty rising from a chair, and a waddling gait. Hip pathology or previous hip surgery may cause pain, reduced hip movement, or mechanical abductor failure. In PACES, you could say, there is a positive Trendelenburg sign when standing on the left leg with dropping of the right hemipelvis. This supports left hip abductor weakness and fits with the proximal weakness and gait abnormality demonstrated earlier in the examination. The memory hook is simple. The pelvis drops away from the lesion, but the weakness is in the standing leg. Do subscribe to the channel for further videos.